Tonight, we're very pleased and very honored to have Andreas Schibler, Pediatric Critical Care Research Group and the Matter Research, University of Queensland in South Brisbane, Australia. He's also an author in the Trend Study group that studied EIT and did EIT examination, which for those of us not necessarily focused in this area is electrical impedance tomography. And we're very interested in the application in mechanical ventilation since ventilation matters. So thank you very much, Andreas. And also joining us is Graham Eot and Melissa Brown. Melissa, can you tell us quickly about yourself?
I'm a neonatal respiratory therapist for 30 years and a pediatric researcher, and worked with an electrical impedance tomography in the research setting in the neonatal intensive care unit.
Great. And Graham, can you tell us a little bit about yourself?
You mean you've forgotten already?
Yes.
Well, I have to apologize because of my voice. And like Steve, an old respiratory therapist, still working, sort of part-time. Yeah, I'm on board with as a subject matter expert in ventilation. I've done a lot of research in the past in ventilation. So I'll leave it at that.
Okay, thank you, Andres, for waiting, and you can take the time you're ready.
So from sunny Queensland, discussion around EIT, and sorry, for some reason, the title came across with my automated slide in a different way. So what I'd like to talk about is actually what we don't know when we mechanically ventilate patients. We have this black box in front of us talking chest. We have no clue what's going inside, what's happening inside the chest. You're pumping air in and hope the best. And so the question is, where do we distribute ventilation? What are our pressures and volumes, and how efficient is it to the gas mixing? And how can the side effects from mechanical ventilation be measured? And we actually lack a real-time monitoring for this kind of distribution of ventilation and lung volumes, because we don't get a direct measure of what's happening in the lung. We assume what the ventilator provides and gets sort of back with resistance and compliance measurement and pressures delivered. We assume that's what's happening inside the lungs as well. And not to forget that when we talk about ventilation, we need to talk about lung perfusion as well, because that's the other side of the equation. So it's about understanding ventilation distribution. So I'm going a little bit outside the topic of EIT first, because it's very important to understand what is actually ventilation distribution. I've done years of inert gas washout research, and that's where my passion came for ventilation distribution and EIT research. So if we look at ventilation distribution, the easiest way or in the end is doing some imaging and seeing where collapsed lung is and how we can recruit lungs. But if you're using imaging techniques, this is a very important part of it. I hope that video goes. This is a axial video of inspiratory and expiratory on the same level of the CT scan. And as you can see, the lung is actually migrating or wandering through the chest. So the lung is not a fixed structure in the chest. It is an organ that actually moves up and down inside the chest with the diaphragmatic movement. And so we have to be very mindful if you're going into EIT imaging, where and what we are looking at inside the chest. And more than almost 50 years ago, Milik Emily has quite nicely as well shown that ventilation is simply not going evenly inside the lung, that the upper lung is more inflated but receives overall less volume change per breath cycle, whereas the so-called dependent lung is the part of the lung that we see most of the volume change occurring. So these are these very basic principles where ventilation is going. And in sick lungs, we need to be as well mindful if we actually can open up lung that has previously been collapsed. And we know that some lungs, they can't be recruited, they can't be opened. So there's no point attempting lung recruitment if this can't be achieved with reasonable pressures. Some of you may remember Neiman's group in New York. They provided quite interesting images of the lung surface in pigs. And the simplest way to demonstrate it is actually using a video. Alveolar space is a silent space. Alveolar space is a space that doesn't actually change in lung volume during spontaneous breathing or in a healthy lung. However, as soon as the lung starts to collapse in disease, as we can see here in this lung video, we have alveoli on the surface that you can see. They're not changing in volume while we're now increasing the pressure with the pressure volume curve. And as you may see here, you get these popping up of alveolar space, and that's the unhealthy part around lung recruitment or tidal breathing in a sick lung. So we have to differentiate. In healthy lungs, we don't have ventilation happening or bulk flow happening inside the alveolar space. Where's ventilation, so volume change actually occurring? If you look at the lung growth in a rat, and it's not unsimilar in humans, we have the development of the airway branching, and then at a certain generation here in rats around the 7th, 8th generation, we see that we have alveolar space occurring, branching off some of the smaller bronchi. And so all dependent on size of the species that we're looking at. So from rat to rabbit, so we have a size jump by a factor 10. We can see that the alveolar spaces are occurring in later generations. Similar is as well true in humans, that infants probably exhibit already so-called alveolar space in a generation of the 14th, 15th generation, where in adults it's the 18th, 19th generation. So what happens during regular breath is that we observe bulk flow, so that's volume change occurring down into the generation of 16th, 17th, 18th generation. Infants have that bulk flow only occurring to the 14th, 15th generation. And after that, gas exchange is determined by diffusion. So we have bulk flow, and then we have a transition between bulk flow and diffusion. And as you may remember, the alveolar space is the silent space where there's no bulk flow occurring. So if we're talking about volume delivery into a healthy lung, we actually not volume deliver into the alveolar space, we only deliver volume down into these very peripheral airways. And then at the generation of 1819, we have a transition from bulk flow to diffusion, or from convection to diffusion. This has been quite nicely modeled as well in adult lungs. And we can see that first the bulk flow is entering the main airways. And then we have this transition time where the ventilation transitions from bulk, from convection to diffusion. And this transition from convection to diffusion, it's called the convection diffusion front, can change from in the disease process. So it can happen that even this front goes down to the alveolar level if you have alveolar collapse, which is obviously the unhealthy part of mechanical support. So what is EIT measuring? EIT is measuring bulk flow. EIT doesn't measure alveolar space unless alveolar space has a change in volume during in and expiration. So in a healthy lung, we shouldn't have any volume or hardly any volume change in the alveolar space, whereas in sick lung, if there is alveolar space collapsed and then reinflated, EIT may pick it up. So EIT is, in very simple terms, for those who have not necessarily a huge mathematical and physical background, is nothing else than an injection of voltage inside the chest. So we have, depending on the system we're using here, a 16 electrode system with electrodes placed around the chest. Between the first and the second electrodes, we have a current injection, and the current injection is nothing else than creating a waveform pattern inside the chest. And if we start rotating now to the third and the fourth electrode and inject there, we create another waveform. And if we do this very rapidly in a high frequency around the chest, we start to generate nothing else than a wobbly waveform pattern that, if the system is static, will have quite a nice network of waveforms interfering with each other. And then when we start to distort that pattern or network of waveforms with a tidal volume change, we get a distortion of this wave pattern. And the distortion of the wave pattern is then analyzed in a mathematical model, and the distortion that occurs gives us information about volume change within the chest. I mean, that's a very simplified approach to understand EIT. It's nothing else than creating these waveforms, distort them, and the distortion gives us information about volume change. Because if we have big volumes, obviously voltage will not transition that easily. If we have collapsed tissue, obviously the current will pass through collapsed tissue much easier with a much lower impedance. So what can EIT measure? There's three simple signals that we currently are interested in. It's the volume change. It is blood volume change as well. So we have air change and blood volume change. Or in experimental situation, we can inject high resistive fluid, or the opposite, highly with a low impedance fluid, and we can inject and measure blood volume uptake or change within the chest. EIT, I mean, when I started with EIT, I was very fascinated, and I thought this is the holy grail of what we can achieve. But we have to be very mindful. There's a lot of limitations with this technology, and that's why I believe it still hasn't made it really into the clinical practice, because there's a lot of assumptions made. First of all, EIT is always relative, or at least to the extent that we have current systems available. We can only measure a change in the system. As I explained before, we have this waveform pattern, then we introduce tidal volume, so a volume change, and we can only compare the change to the baseline. So it's all a relative measure, and that needs to be calibrated. The EIT imaging is based on a reconstruction algorithm, and the reconstruction algorithm assumes a certain chest size and shape and volume of the lung within that chest, and it's only as good as the reconstruction algorithm used. So the great algorithm that is mostly used is probably one of the most advanced algorithm, But again, based on a lot of assumptions, we're getting better with it. But we're certainly not there yet and accurate as, for instance, the measurement of lung volume with a CT scan or other technology. There's a lot of assumptions as well and rules around it. We need a uniform amplitude response. As I explained before with the CT scan, we need to make sure that we measure the same position. There's a lot of artifacts in the signal, or it can occur artifacts. We look at shape deformation as well. So if someone lies on the left or on the right side or in prone or in supine position, the chest cavity changing in its configuration, and EIT doesn't take that into account. Resolution can be achieved with more electrodes around the chest, but it becomes very cumbersome to apply these electrodes. And there's a lot of problems with electrodes interfering with the skin. We've done sheep experiments. Sheep have a very oily skin. And so if you place electrodes on a shaved, clean skin of a sheep, you don't get anything. You have actually to place the electrodes inside or around the chest wall. You have to suture them in. Piglets work better, and even in adults, depending on the body fat composition, we may get quite a different response and response to voltage applied to different humans. We've got even differences between females and males, which we have to consider. Now, if we look at the EIT examination, we got these raw images that nicely pop up on the screen, and then we place them into so-called functional images. That means the images are going into a comparison between the baselines, so functional images, or we measure parameters that are obtained from image analysis. And image analysis, I can tell you there's about 500 different indexes, and you can generate out of an EIT image. For the regular user, it becomes very quickly very confusing. So I still think EIT is best when we look at regional and global end expiratory lung volume changes. The simplest one, and we've done some work around this as well, is just to demonstrate that if you disconnect and open suction a patient, that you use tremendous lung volume, which is very helpful for educational purpose. So if we educate nurses and show them that after suction you lose significant lung volume, and if you just reconnect the patient afterwards, that you don't go back to square one, that you in principle should perform a lung recruitment maneuver. As you can see here in this, we done with David in Melbourne in piglets, and on the right hand side this is a human equivalent. So as soon as you start disconnecting, that's the second data point on the left hand side, we start sucking basically air and secretion out of the lung, and you can see that the lung volume drops quite significantly, and this is closed versus open suction, and you can see that there's hardly any difference between closed and open suction in neonates. And if you just reconnect, it gradually increases again your end expiratory level, but you certainly don't get better. And we hoped after suction that we have better ventilation, but this is not true. And that's why we've done a study in children where we performed suction, and you can see that these 3 episodes of suctioning, every time again you have, after the handbagging, a disconnection, handbagging, disconnection, you keep on losing lung volume. And if you do a simple recruitment maneuver by just doubling the PEEP after reconnection, you regain or even improve the lung volume after suctioning. So in our current practice is that we do perform a very simple lung recruitment maneuver that we double the PEEP for 3 minutes after disconnection and go back to the previous PEEP level just to maintain lung volume. David showed as well in this experimental study quite nicely how EIT can measure lung volume change if you increase the PEEP or the continuous distension pressure here on the inflation limb and then on the deflation limb in a RDS model. And as soon as you deliver surfactant in the upper panel, you can see that the so-called PV curve looks on a much higher level and a much more favorable level. So EIT allows you real time to assess these data points bedside, and you can assess as well, for instance, the gain that you get after surfactant delivery. Or the opposite, you can measure in patients the ventilation distribution by looking at how much ventilation is distributed just in these quadrants of the lung. Here there is left lower lobe pneumonia, or in more or less in the posterior parts. And if you superimpose the perfusion image, I'll go and talk a little bit about this later, you can even see how the so-called VQ mismatch is dependent on which region you're looking at. The ventilation perfusion ratios are very different depending on which quadrant that you examine. We showed as well that if you introduce a lung injury, that the ventilation starts really shifting over time. So we had sheep in left lateral position, and the left lateral position is on the right-hand side of this histogram. This is pre-smoke. The left side is on the right side, so it's the opposite orientation. So when we start pre-smoke, ventilation is more distributed into the left lung than the right side, right lung, which is consistent that the dependent lung is better ventilated. This is 5, 15, 60, 90 minutes and 120 minutes after smoke delivery, and smoke is delivered into the better ventilated lung. So smoke is delivered into the right lung and into the left lung, sorry, and we injure the left lung more than the right lung if you're in left lateral position. And you can see how that shift into the right lung, so the so-called independent lung is occurring. The lung on the left side starts to be injured. So it's quite nice to have a real-time monitoring of where ventilation is distributed. We took the EIT imaging even further in, and we used hyperpolarized helium, which is sort of the state of the art to look in MR imaging where ventilation is distributed. And in this paper, we could quite nicely demonstrate that we can reconstruct a very similar ventilation distribution in rats compared to hyperpolarized helium. However, you can see that the resolution of an MR is, of course, multiple factors better than EIT. So we get just a crude analysis of where ventilation is distributed. But what we did is, as well in this rat study, we proned and supined these rats and used different tidal volumes. We did then the same as well in tidal volumes in in lateral position. And you can see that position-dependent ventilation distribution is very important. So if a patient is in prone or in supine, it really distributes the ventilation always into the so-called dependent part of the lung and not in the non-dependent part of the lung. And EIT is picking this up very nicely. And so we can really monitor real-time regional ventilation distribution. Now, ventilation is not all. We need to look at perfusion. And it's quite easily to pick up if you have an adult breathing that there's a lot of artifacts on an EIT signal. It's actually not artifacts, it's cardiac oscillation. So if you have a healthy subject holding the breath, you can see that these oscillations are on top of the signal. And you can do that in the dependent lung, you can do that in the non-dependent lung, but this part of the signal is as well of interest, and we call that the cardiac oscillations. We've looked more into the details of that signal. We did a filtering process. We looked at the frequency, so that's the breathing frequency here in adults. And we picked up a small signal around 60, 70 beats per minute. And that's obviously within the cardiac oscillation range. As you can see, if you reconstruct the image based just on the frequency around the breath rate, you get a normal EIT signal. And if you do the same filtering, you can even see here the pulmonary artery coming out of the right ventricle. And if you want to be very, very clever, you even apply and use a ECG signal to gate basically your filtering process. And if you are very astute, you can see that impedance change here is occurring in a positive direction, and around these areas, impedance change are occurring in a negative direction. So we have a phase difference where the heart is pumping and then distributing with a phase lag into the lung, and that's what we expect, that the phase of the heart contraction is not completely in phase with the blood volume distribution within the lung. So by using EIT and ECG gating, we can even analyze the perfusion and the time sequence of volume distribution within the chest. We looked as well if we can measure basically VQ mismatch. Just look at the lower part of this graph here. If we are in prone or supine position and look at the VQ match or mismatch, we can pick up the dependent lung in, for instance, here in lateral position. We get much more uniform ventilation distribution in the dependent lung than in the non-dependent lung. That can be easily picked up by EIT. So we have actually tools available currently that would tell us if we have equal ventilation perfusion or if we have a mismatch between ventilation and perfusion. These techniques are quite easily to implement, but haven't made it out of the research space into the commercial application of EIT. A few interesting studies are recently coming up using EIT in mechanical ventilation. And there's some quite interesting so-called dynamic analysis and assessment of EIT in the ventilation space. I'll take you first through a healthy experiment. We've looked at healthy infants and when they sleep, and they perform sighs on a quite frequent interval. And when you look at where ventilation is distributed, the black dots are the so-called anterior aspects of the lung, and the triangles are the posterior. So that's the dependent lung, and that's the non-dependent lung. And if we ask first, where is the first part of the breath going to? And where is the later part of the ventilation going to? We can describe that by using the filling index. If the filling index is above 1, the first part of the inspiration goes into the anterior lung. And the latter part, but the majority of the volume, is going in the so-called dependent lung, in the posterior lung. And you can see when they breathe normally, they keep that rule first a little bit into the non-dependent and then the majority into the dependent lung. When they perform a sigh, they reverse that. And you can see that during the sigh, we distribute the volume first into the dependent lung and then followed by the first breath. We see the rules are is applied again. So somehow a sigh is here to reset the ventilation distribution. Or we probably hypothesize afterwards, it's probably more resetting the pressure sensors and receptors within the lung and resetting the control center of the brain to manage again a regular breathing afterwards, because there's no reason to explain why we have a complete opposite of ventilation distribution during a sigh when there's no indication that lung volumes are lost or changed over time. So by using a filling index or some dynamic assessment, we can analyze where we ventilate and how the dynamic of filling is occurring. Here is a simple Eot analysis of inspiration that's performed by using a positive pressure support. This is the globe, the upper part is the global impedance change, and we can see the volume change during the inspiration is increasing overall. However, if we see the timing where the ventilation is start to rise, we see first are the areas they are in the so-called independent part of the lung, whereas the dependent parts, they lag with a time behind the non-dependent parts. So there's different timing in the filling within the chest. It's a different timing within a positive pressure ventilation. We can see even if we assist a breath or if we deliver a controlled breath, you can see that the impedance change in the posterior and anterior lung have quite a different filling characteristics. If we use a controlled breath, yes, the anterior is here in a sick lung, initially a bit faster compared to the posterior, but they're more or less the same. Whereas if we assist, that means we use the diaphragm, you can see that the posterior part of the lung is taking the first brunt of the volume change, whereas the anterior part is almost doing the opposite, loses volume. Don't get me wrong, it's probably not losing lung volume. It's probably just a movement of the lung within the chest that pulls the upper part of the lung down by losing lung volume, not necessarily by indeed lung volume change within the chest. It's just pulling that part of the lung down, as I showed you in the first slide. And I think there's a lot of misconception if people observe that. They call that Pendelluft, which I don't think is Pendelluft. It is just the movement of the lung within the chest. But nevertheless, in a very nice study done by Yoshida a few year ago, he showed that with assisted ventilation or pressure-controlled ventilation, that means the diaphragm is working. The diaphragm is not working in this pressure-controlled way. If you can look at the impedance change in these 4 different zones, from the non-dependent to the dependent lung, you can see in pressure ventilation in a not spontaneous breathing, we can see roughly there's no big difference in the timing. Yes, we may see some lateness of filling in the dependent lung. Whereas in assisted ventilation, where the diaphragm has activity, you can see again this drop in volume. Again, I don't think it's necessarily a drop in volume, it's a change in the geometry of the chest. But you can see that the volume uptake and change in volume is quite significantly different if you compare, for instance, zone 4, so in the dependent, to zone 1. So it's quite interesting to see the effect of spontaneous breathing in mechanical ventilation. If you take that even further and you optimize PEEP, there's in this study quite extensive description of how they optimize PEEP, and you optimize PEEP with spontaneous breathing or without spontaneous breathing. We see as well, let's say first again, if you don't optimize PEEP, you don't get much benefit even in pressure-controlled ventilation. If you then optimize PEEP and have the support of the diaphragm, you can see that these volume changes are quite significant. If you use low PEEP and you have a lot of lung to recruit, these changes between the upper lung and the lower lung becomes even much more. So that means that the diaphragmatic assistance is particularly relevant to the dependent lung or the lung that's more affected by the disease. Mm. So what do we know in EIT and ARDS? There's a lot of dots. We don't know that much. And the problem is probably because the commercially available EIT brands are rare and unfortunately are still quite expensive. But in the same experiment as I showed before, if you look at EIT images and positron images, you get quite nice distribution of the ventilation if you actually tackle optimizing PEEP. So that means optimizing PEEP plus spontaneous breathing, and optimizing PEEP without spontaneous breathing. You may see or get a hint that these so-called dependent parts of the lung, particularly during end expiration, are less well ventilated than when you have as additional spontaneous breathing. If you use a low PEEP, no surprising, and everyone knows, like we know from previous description by Galtignonis with a large series of CT scans, as you can see, low PEEP, you get immediately these collapse dependent lungs, and you don't achieve that much more. But still, if you compare to no spontaneous breathing and spontaneous breathing, here at the end of the inspiratory effort, you may see that there's still spontaneous versus not spontaneous breathing. You get ventilation distributed to the posterior lung. Where maybe there may be benefit in using EITs in analyzing and trying to figure out where is optimal ventilation, because as soon as we start increasing PEEP, we have either, we have over distension. So if the PEEP goes from right to left, so from 4 to 26, we have, with increasing PEEP, we get over distension happening, whereas low PEEP, we have collapsed lung. If we increase PEEP, we start to open up lung. So we get benefit for lung being reinflated, but we get at the same time over distension. And if you calculate then the ratio between over distension and collapse, you may find a sweet spot. And as usual, it's the blood pressure, it's a drug dose, it's ventilation dose. There is an individual sweet spot where a patient may benefit from titrating PEEP, where you get less disadvantage, more advantage, or sort of a compromise in that sweet spot. And EIT indeed allows you for an individual patient to configure this sweet spot. So we don't necessarily have to use an ArtsNet table where we have fixed measures of PEEP and FiO2 ratios based on PF ratios. We have actually a tool in our hand that can titrate the individual correct PEEP level. Similar here with a recent study in COVID patients. So just to demonstrate that COVID patients do not behave different to any other ARDS patients, they showed in this study as well that in COVID patients, somewhere there is a sweet spot where they can achieve optimal ventilation. For this particular example, a PEEP of 22, quite a significant level of PEEP, but based on the dynamic behavior and the over distension or the collapse of this patient, PEEP titration may be offered by bedside monitoring of these patients. So I don't want to go much further than this. I'd like to just ask a few questions or future steps that need to happen, particularly from the industry side. We certainly would have the capacity with the modern processor capacity to integrate EIT into the ventilator. Drager has an external EIT that links into their ventilator to synchronize EIT measures, and Temple as well has an external EIT device. But with the current computer capacity, I don't see any reason why EIT can't be part of the lung function equipment that a ventilator can provide. The biggest problem is the simplification of the EIT imaging. Not everyone is an expert, and we all can generate nice, colorful images, but what do they mean? When we have a nice color change, everyone says, wow, but how that actually is interpreted is another equation for us to translate that into clinical pressure. I think what we need to further investigate is the regional pressure volume relationship. And I'm talking here not regional pressure volume relationship, I'm talking here about regional power distribution. Because we have pressure as a signal, we have volume change as a signal, and we can actually measure regional power distribution. No one has ever done it. No one has shown how regional power distribution is occurring. And I don't know anyone who is currently even doing animal experiments on it, but we can even go and take the power concept further into regional power. So I believe these are the next future steps that we need to look at, and they're obviously open for discussion. So thank you very much.
Thank you, Andres. It's a very good, very excellent presentation in an area where it's, I think, exciting in terms of our quest for better mechanical ventilation and understanding mechanical ventilation and its relationship to perfusion. I am constantly talking to ventilator manufacturers who want to focus on ventilation completely, and you know, there's something else in the chest as well.
I mean, where I started in ventilation distribution in spontaneous breathing during my training as a pediatric respiratory physician, and we deal with the black box during mechanical ventilation, and we base our assumption on optimal ventilation by measurements at the airway opening. And yes, if you use balloons, we have some pressure signal as well from the chest, but it's again outside the region of interest. We have means of assessing volume change within the lung using EIT. And on top of it, we would have certainly as well inert gas washout technology to accurately measure ventilated lung volumes. And it mystifies me why we haven't progressed from, we know how to measure volume change using EIT as a relative volume change, and we are interested most likely in relative changes anyway during mechanical ventilation. And it mystifies me as well why we don't use inert gas washout technology to measure the baby lung that we hypothesize exists within an ARDS model.
Mm-hmm.
So I still believe that the technology is sort of there, but we haven't embraced it yet. And I think the clinicians' hesitance is because it becomes too complicated.
I want to let some others talk, but I certainly could respond to that in terms of technology adoption and the question of why I see EIT in the pediatric and such discussions in pediatric and neonatology versus adult. My first inclination is the labor intensity maybe of the application. And, I hate to say it, but well, I'm not going to say it. We know what I'm saying, but we really do pay. Labor doesn't get in our way when we're dealing with children or when we're dealing with pediatric patients or neonates.
As I'll apologise again, I've lost my voice, so I'll do my best, Andreas, to try and I've written down a couple of notes. Just number one, are all EIT systems equal?
No, and that we're starting off. That was part of the Trend study group. Yeah. To sort of agree on what is current standard, and that's where the problem starts. We can't agree on the algorithm. We can't agree necessarily on what are the basic parameters that we can obtain from EIT. I mean, in the Trend, we have published that in chest. We could then agree and say that's probably what the stand should be. But it's similar like to, every country has a different currency and we can't agree which currency is, accepted. It's the same as well between industrial standards. Drager, very early on with their Pulmovista, went on their own, and they even do not share their algorithm, what they're using. Swiss Tom is then the next on the line, and they were very open with their algorithm and what they used. They used the Great algorithm and are open. Temple, again, is a more closed system. And it's all about the commercial protection and of course the commercial interest. But as long as we have these competing interests between the clinicians or the researcher wants to have an open platform, and the commercial aspects, we're bound by these constraints.
I think too, you know, you did a great presentation. Honestly, it was very nice. I think we all agree. The thing is going to be the complexity, as Steve said, because you know, we're trying to teach clinicians how to use 3 waveforms on a ventilator and say this is what's happening. Now you're going to say, oh, by the way, as well as having the chest electrodes there, you need to have a whole bunch more around there, you know. And if the skin is, like you said, in the animal studies, is, you know, you've got somebody who's cold and clammy or other issues, then the impedance will give you maybe misinformation or harder to interpret because the algorithms don't take into account. Am I right to say that?
They assume, you know, there is some equipment or software that even measures skin impedance first, or within even the old Göttingen algorithm, the skin properties were first analyzed and calibrated. And so some of it is taken care of, but you're absolutely right that we have so many unknowns still with the EIT that if we voice these unknowns to clinicians, they will say, okay, you don't know what you're talking about, so I can't believe what you're showing me. And that's the disadvantage, that we're still struggling to have a uniform approach, a standardized approach. I don't think that assumptions are necessarily a bad approach, but as long as the same assumptions are upheld, then we can start working from a baseline.
Just one last question that I'm sure Melissa will be jumping for her turn. You showed some nice scans there from Takashi Yoshida, his scans of high peep, low peep. And it made me think about, in the adult population, how many clinicians around the world still use T-piece weaning? You know, put somebody on a T-tube and let them breathe. If you were to do EIT on them, I think people might be horrified of how much the lung is really working. Where if you show this on PEEP, different levels of PEEP, how PEEP is, you know, provides more, I suppose, easier breathing would be the way of putting it. Would you agree that T-piece weaning is probably not the way to do it?
Look, but based on what you see, or what I've shown here, as well, as soon as you disconnect the patient from PEEP, there's tremendous amount of lung volume lost. And, you know, I mean, Melissa, you can talk about, you know, neonates. Neonates, they breathe much closer to the so-called closing volume. So if you look at the FRC in a newborn, it's around 20 mils per kilogram, whereas an adult has FRC between 30 and 40 mils per kilogram. So it's higher up. So what happens in infants, that's why they have an active larynx during the expiratory phase. I mean, neonates, they close, they not close, they narrow their vocal cords during the expiratory phase to prevent natural collapse of the lung towards the end of the expiration. And once we start maturing and our cartilage of the bronchial trees are more matured, we don't need that dynamic collapse prevention during the expiratory phase. And now you just take this experience into the adult or disease environment, you will see that dynamic collapse during spontaneous breathing with an endotracheal tube where you can't regulate your FRC anymore using these mechanisms. You bypass the larynx. And as soon as you bypass the larynx without PEEP, you can't control FRC even in healthy adults.
Thank you. It just supports my belief anyway. Yeah, Melissa, you go for it now. It's your turn.
Well, what was interesting in the neonatal environment is the dynamic breathing of the babies and how difficult it was to maybe get a measurement because they're breathing so dynamically, and maybe you want to use it to titrate your PEEP or your CPAP level to get optimal inflation. And the baby is breathing erratically and then very deeply. And so you think you maybe have a setting, you have something that maybe is beneficial, and it completely changes instantaneously. So it's very difficult, I thought, to implement right at the bedside. I think it'd be interesting if some of these commercial products gave us some sort of averaging function where they would tell us how, right, so that we could set it up, sit, wait, and then look for an average number maybe to come up over a longer period of time so that we could use it for some sort of decision making. Do you think that's something we might see?
Look, I've done lots of studies with Judy Hoff in preterm. I mean, she's been the one who's been starting to measure in 800-gram neonates, preterms. And we were absolutely taken away by the erratic breathing that we observed. And we initially thought this is all artifact. Can't be true because the FRC needs to be stable. But I don't think that spontaneous breathing preterm infants do follow the same logic like an adult baseline breathing. They adapt and change FRC on a quite, we call it erratic, but it's probably based on a fractal model more than anything else, because we looked at fractal distribution. We did some fractal analysis in the spontaneous breathing preterm, and you can actually have, if you look at similarity, we talk about, I don't know if you understand what the similarity means. Similarity in fractal mathematics means that, let's say if you look at the tree, you've got the stem, you've got the brown, the tree, and if you take a branch and put it upright, it looks sort of similar to a small tree. And then you take the next sub branch and it looks again like a small tree. And so they have all these similarities. And if you start placing these similarities in, call it a mathematical equation, you all of a sudden see that the so-called branching of a tree is following quite logic of fractal pattern. And we've seen in the breathing pattern of neonates and preterms that they follow as well a fractal pattern. To our bare eye, it looks like chaos. We can't put a regularity in there, but as soon as you start looking at the similarity and not the regularity, you are starting to find out they repeat that breathing pattern over time again and again and again. But with our blunt eye, we can't see it. And that's why when you look at the EIT measurements, you can't put a finger down. If you look at the waveform over a minute or even an hour, you think I can't analyze that because it doesn't make sense. We need to change the assumption on how we analyze it. So with our, I want to have a stable FRC, you're not going to get it. You need to look at the FRC changes in a fractal way and not in what we use normally as a regular way. So when we look at these analysis methods that we need to apply, particularly in preterm and neonates, we need to use different assumptions and models. And believe me, if we start talking about fractal mathematics, you lose any clinician.
Well, that was one of the question I got when I was using the device, is people trying to come up and look and seeing this single band of probes around a chest and wondering how that can give us a three-dimensional, multi-regional picture of the entire chest when there is a single plane with these electrodes. Is there a simple way to explain that to people?
I mean, if I understand you correctly, people would love to have the total lung measured, or a picture of the total lung.
Yes.
It is possible. I mean, people have done it by using several planes, 2, 3, and even more belts around the chest, and you can imagine how that looks like, particularly in the preterm infants. It's not feasible. It's a very important limitation of EIT. You look at basically an eclipse volume inside the chest and not much more. So if people are asking, I'd like to have a look at the total lung, like I've shown in the hyperpolarized helium measurement, it's simply not possible. And I don't think we will ever get it. We have to live with that limitation with the EIT, that you have only a slice. Of course, in a preterm, the so-called slice to body weight ratio is much more in favor to capture more volume compared to an adult, but we limit it with one slice only.
Yeah, I thought there was a couple interesting applications I thought were helpful with EIT. I thought one thing that was very interesting was maybe the ability, once it's integrated with the ventilator, to capture pneumothorax as they're occurring. And I've seen some interesting video by your colleagues that demonstrates that. And that's a big problem in the neonatal intensive care unit, is not recognizing air leak early on until it progresses to be a very large problem. So that seems to show up pretty clearly on the device. I thought that was very interesting. And also positioning of the infants and lung volume with positioning, and what difference you could get by proper positioning. And that might be kind of a very gross, easy thing to demonstrate to somebody at the bedside if it was built in, that like, hey, look how much better your lung volumes are just proning this patient versus being on the supine.
Yeah. Judy Huff has published a few papers around the positioning in preterm infants, and could quite nicely shown that with the positioning, you improve again ventilation distribution. And because you guys are using as well, quarter proning, full proning. I mean, the neonatologists, look, you guys are always 20 years ahead of the rest. In adults, we started talking proning about 10 years ago or 15 years ago, where in neonates, what are you talking about proning? Yes, that's what you do, isn't it? It wasn't even a topic. It's not even a discussion in the neonatal world. I remember in the 90s when I trained, it was normal for a neonatal nurse to, flip the patients between shifts or hours when they thought, the SATs are dropping. Let's turn the patient. SATs are much better now.
Yes, exactly. And it started, Pete's ICU was pretty good about that too, way ahead of adult ICU. But nice tool.
It's much easier, if you flip around 1 kilogram compared to 150 kilogram, a different ball game of intervention.
Touche.
Definitely. So I am reminded hearing you guys talk of an early quest we had in the 80s to use impedance plethysmography for a different really intended use, but to measure respiratory rate and try to identify dysynchrony during spontaneous breathing. And we followed Marvin Sackner and Marty Tobin and the whole group trying to create that. But the biggest challenge we always seemed to have was the application, simplest thing, the application of the bands and keeping them in the places we wanted, and getting agreement with not only the patients' families, but really the nursing staff to keep this in place while we were gathering data. The other thing I'm reminded of is when we First, when I first wrote the product specification for the Bicor unit, for the esophageal balloon unit, I was like a kid in a candy store. I was just thinking of all these iterations of delta Pez and transpulmonary pressure. And I was reading, I could do counts of 3 and pick up early effects of anesthesia. And people, I mean, I had a thick thing full of things I could do with it. In the end, it boiled down to one. It went all the way back to the signal that we were measuring, which was esophageal pressure. And that's what I think today is integrated in Vair's equipment. And it's
And
kind of funny.
it's I would assume that EAT, if it's going to find its place, is simple as, can I observe a volume change? And maybe if someone understands dependent and non-dependent lung, okay, where's the volume distributed? And if I turn someone from prone to supine or opposite, well, I can see the difference. I think that's how far it can get. Maybe as well, if you perform a recruitment maneuver to demonstrate where the lung has opened up, you may get some aha effect from clinicians. But once you start talking about filling index or global inhomogeneity index or anything else, yeah, I don't think it's going to happen.
Yeah. Needs to be. Well, we hope for progress in providing us tools at the bedside. Anybody else? Any questions for Andreas?
I'll just say, Andreas, I agree with that slide you showed, though, with suctioning, post-suctioning and de-recruitment. I think there could be a lot of teaching that happens at the bedside, not where you're learning what happens in your day-to-day care of the patient. And that how we really, there's things that maybe we teach at the bedside that, hey, you really have to do a recruitment maneuver after your suction, but does it happen? But once people saw that graphically, day by day, it would happen.
Yeah, and we see that with the nurses. They're quite fascinated to see how much, damage or harm they even do during suction procedures. And quite interestingly, we published a study where we did in cardiac patients prior to cardiopulmonary bypass. We asked the anesthetists, okay, you anesthetize and you establish regular ventilation, and you show us as well how you ventilate and handbag these patients, and how do you optimize lungs prior to bypass. And we had blinded for them the EIT measurements while they were doing their stuff. And when we then showed how much de-recruitment occurred up to going on bypass, they were completely taken away. They didn't realize how much de-recruitment happened during the whole procedure from induction to go on bypass, how much lung volume they lost. And they were as well quite taken away how much tidal volume they use during handbagging. You know, how much pressure they used and how much tidal volume they used.
Amazing. So it definitely has promise also as a practice-changing teaching tool.
Yeah, I think it's a fair point. It's a good teaching tool. Yes.
Well, it's similar to when we began to have numbers that we could read on the ventilator as far as tidal volume. We saw the same thing.
Yep. And lo and behold, waveforms.
Yeah.
You mean you don't trust bellows?
The anesthesiologist did. I remember being asked for the Monahan quite a bit because they could see the bellows move.
Correct. The old MA1.
There's some value in that, seeing movement.
Or the right to respirometer.
True. Well, thank you so much, Andreas. This has been a wonderful talk, and we appreciate your time. Thank you, Melissa and Graham, for participating. And we look forward to you guys joining us on the next Ventilation Matters. For now, everyone, breathe easy.
Okay, thank you. Take care.